Okay. Well, welcome everyone to Pediatric Teaching today. We've got quite a lot of people online and people from many different places around in PNG, so it's great to see you. Today I wanted to talk about a topic we haven't talked about before, and probably there's not a lot of teaching we've done before on this topic, unless except for those who've been working a lot with oncology patients. But I wanted to talk about pediatric palliative care, and it's a fundamental um, topic for pediatrics because so many conditions we look after. For some of the children, they'll have palliative care requirements at some stage during their illness. Of course, we aim to cure all children, but many, children aren't able to be cured, and they have palliative care requirements. But I wanted to really expand on what you know about palliative care, because often people think of it as really just being about giving morphine or relieving distressing symptoms, but it actually is very holistic care. It includes the relief of troubling symptoms or distressing symptoms of pain, etc., but it's much more than that. And as I said, for pediatricians, we need to have a good understanding of palliative care because it includes many conditions that we manage, whether it's cancer or HIV or children who've got progressive neurological problems, for example, newborn babies with severe congenital malformations or newborn babies with severe brain injury from birth asphyxia, all many different severe diseases have a palliative care requirement. It doesn't mean that all those children should be on palliative care or they will be on palliative care. It just means that there may be a palliative care requirement at some stage during the child's illness. The common factor is not that they have cancer or they have HIV, but they have a disease that's potentially life-threatening. It doesn't even have to be life-threatening, it's potentially life-threatening. And I include this photo. There's no other photographs in my talk, but I include this photograph because I really like what the photograph represents. This was Dr. Matthew Santagabata, our pediatrician who completed his training last year. And this is him with a young boy in the Port Moresby General Hospital. And clearly the young boy is very unwell. He's quite wasted and cachectic. He looks unwell. But you can see that Matthew is looking him in the eye and he's smiling at him, even through his mask. And the boy is smiling back. And Matthew's holding his hand. And it represents to me holistic, compassionate, palliative care. And that's what it is about. Um, it's more than just knowing the dose of morphine to give, although we will cover that later on. But I want you to have a idea that palliative care is holistic care that encompasses many things. For many children, um, we need to balance palliative care at the same time as we're giving curative care. And I've just given a couple of examples. For many children with serious medical conditions who are not at the end of life, they may not be going to die. Palliative care may still be needed at some time as as well as the ongoing efforts to cure the child. So you might still be focused on trying to cure the child, but the child will have symptoms, troubling, distressing symptoms that the palliation of those symptoms will really help the child get better. So, for example, a child with advanced HIV who will have symptoms that require palliation, but still the child requires antiretroviral therapy, optimal antiretroviral therapy to try to improve the child's immune function. And you might get immune reconstitution and the child becomes well again and puts on weight and does well. But on the other hand, the child at the same time needs relief of troubling symptoms. A child with cancer may be undergoing chemotherapy, but will still need the palliative relief of symptoms, um, even if the aim is still to cure the child. So I guess I'm trying to convey that palliative care and curative care can run in parallel, and we need to be very, I would say, literate about what palliative care means. And of course, for some children, death is inevitable, and palliative care is the main focus as part of an end of life care. But what I'm trying to say is for the majority of children that require some degree of palliative care, it's not that they're just about to die, but it's trying to improve their quality of life during their treatment or as they improve. In palliative care, families are central to all we do. And I always think it's useful to consider for yourself, well, what would families want? Now, what families want is so widely varied, but these are some common things that I've found that families want. Now, it's not universal, but these are common things across many different cultures, many different family backgrounds, economic backgrounds, social backgrounds. Firstly, they want a say in the care, that to be partners in care. And that's what palliative care, as I said, is families are central. They want to be partners in the care of their child. Families often want to focus on living rather than dying. And this is important because if we talk to families a lot just about dying, you miss the mark on what families really want to do. They want to focus on living, on the next day, on the next week, and what they're going to do. So palliative care should also encompass making the most of the time the child has left, improving the quality of life and enjoyment of every day. That's what palliative care should be. Not so much focus on the end of life dying, but on the making the most of life, however long it will be. Families often want to focus one day at a time. Doctors want to project in the future and predict whether or not a child's going to survive or die, but projecting forward to what might happen in the future is often very painful for families. So they just want to focus on one day at a time, and we should let them do that. Let them focus on one day at a time rather than forcing them to project forward as to what might happen in the future. For many families, they have religious or cultural needs, and I think this often influences their perspective on death and dying. I mean, it's obvious that it does, but it can also give them strength and resilience. And so I try, if at all possible, to facilitate religious leaders or their pastor or their whoever it is, the imam, to attend the child in hospital if that's what the family's wishes are. And for some hospitals have like restrictions around who can visit, but I think when a child's under palliative care, it's very important that we should allow unrestricted visiting, family visiting. I've had many children have had culturally appropriate ceremonies in the hospital, even in the intensive care, whatever food the family want to cook and bring into the hospital. So try to enable the wishes of the family, find out what the family want. Also consider palliative care at home as an alternative to hospital care. Many families would actually be very happy if they could be supported to give palliative care at home so that the child wasn't kept in hospital unnecessarily. And it's possible to do in many circumstances. And many of the treatments for pain control and relief of distress what we often think is that when you give analgesia and pain relief, morphine, etc., what are doing is really trying to improve the quality of the child's remaining life and enable them to enjoy the time they've got left to be with their friends and families. And it's been shown very well that if you provide children with good palliative care at home, they often survive longer than those who receive intense medical care in hospitals, where they're likely to get nosocomial infections, maybe get over-medicated, get complications, etc. If they're at home and the family's looking after them, then it's been shown in many studies, both children and adults are likely to live longer if they're getting good palliative care at home. I've said that palliative care is holistic, and it's not a healthcare failure. Sometimes healthcare workers can feel a sense of failure, as if the talk with families about palliative care is an admission that nothing more can be done for the child, because there's a lot that can be done. And it's not just about analgesia and troubling symptom relief. As I said, it's holistic. It's a comfortable, loving environment. It's a enjoyable nutrition, social support for families, for parents, and caregivers. It's looking after the child's tangible needs. It might be getting them a wheelchair so they can be more mobile, or a suction machine, or a hospital bed for home, something that can really provide tangible support to them getting home, or palliative care in hospital. It's holistic. And I always try to establish early on the goals of care for families, what they really want to do. Is it to get home or to celebrate a birthday? Many children and adults, when they're coming towards the end of life, there are milestones that are coming up, whether it's their birthday or it's a family event, a wedding even, that they might want to get to. And many children hang on until that happens. So establish some goals of care. Maybe it's even as simple as getting outside in the sunshine rather than being in hospital, or even seeing their friends or their family, having their friends from school visit, or even having their pets in. I have many children that really just want their pet dog to come in and spend time with them. And it's important to know, like, we often think palliative care is only going to last for a few days or even a week or more, but palliative care is not always of short duration. And I've had patients that have been under palliative care for many months or even years, and that's just improving their quality of life while they still have the next day and the next day after that. So it's not always of short duration. There was if you remember, the great US President Jimmy Carter, he just died recently, I think at the age of 100, but he went into palliative care at the age of 98. I think it was 1998. And so he lived for 2 years in palliative care. And so it's not always of short duration. It can be a long time. And as I said, if you get good palliative care, then often people survive a lot longer. I'm going to talk now about analgesia. So that was palliative care in general, but let's talk about analgesia. And the first thing to do is to understand the causes of the pain. If a child's got pain, then try to understand the causes. And it might be that some other interventions besides pharmacological analgesia might help. It might be treating the cause of the pain, like treating a painful fungal infection, or treating some children with who are on opioids get quite constipated. That can be painful. And then sometimes we think we have to give them more opioids, but actually it might be just treating their constipation. Or if they've got pressure areas, maybe relief of the pressure areas can be of benefit and reduce their pain so that their analgesic requirements are less. But when you do give analgesics, well, it's important to follow certain rules. Firstly, to give it in steps according to whether the pain is mild or moderate to severe. And second principle is to give it regularly by the clock so that the child doesn't have to experience a recurrence of severe pain. We all know that each paracetamol or morphine dose, it works for a certain amount of time, say 4 to 6 hours. Well, you don't wait for 8 hours until the pain's been there for an hour before you start giving the analgesia. Try to give it by the clock, every 4 hours or every 6 hours, whatever the duration is for that particular analgesic. You give the most, for children under palliative care, it's really important, give the simplest, most effective and least painful route of administration of the drug, orally where possible, or by a nasogastric tube. But intramuscular injection obviously is painful, so normally we wouldn't do that to a child under palliative care. There are some subcutaneous infusions you can give of morphine that can be quite useful. That's not very painful. That's actually quite tolerable, and it can be very effective too. You should tailor the dose. So different children have different dose requirements, and that changes over time. So you should progressively titrate the dose to ensure adequate pain relief. What the dose they needed 2 weeks ago probably won't be the dose they need now. And it's likely to be that they'll need a higher dose, and that's not a problem. You should avoid unnecessary painful procedures when you're as I said, intramuscular injections are very painful, so it can be painful. So don't give those, but give oral medications where if you can, give it by a nasogastric tube if you need to, subcutaneously if you can. And if a child has to undergo a painful procedure, whether it's just putting in an IV cannula or whatever, give some analgesia, even if it's simple analgesia before you do that. Give some paracetamol, put some lignocaine gel on the area where you're going to give the injection. But just consider all painful procedures, whatever they are, that you should give some sort of analgesia. And for many children, there's psychological and social factors that contribute to the pain. They might be scared about what's happening. They might be missing their family. They might not have the comfort of their family. And so it's really important that we address those psychological and social factors that make the pain worse, rather than just give more morphine. If a child's got mild pain, we've talked about analgesia before, but if a child's got mild pain, then paracetamol or ibuprofen, a non-steroidal anti-inflammatory agent, to children over 3, you shouldn't give non-steroidals to children under 3 months, apart from those that have got a patent ductus arteriosus. But generally speaking, we try not to give non-steroidals to young infants. But for paracetamol or ibuprofen, it's quite safe to give orally to children over the age of 3 months, and for children under 3 months, we usually use paracetamol. These are the doses that you should use. Often, when you look up doses in a book, the doses are about 10 milligrams per kilogram, but actually you can give a higher dose, 15 milligrams per kilogram, every 4 to 6 hours of paracetamol, and that's quite safe. Not more than that, but you can give that much. Ibuprofen 2, 10 milligrams per kilogram every 6 to 8 hours, certainly twice a day. Sometimes I give it twice a day, but every 6 to 8 hours is quite safe to most children. Obviously, if you're giving ibuprofen, then you should be also ensuring that the child can feed okay, so that they're less likely to get stress ulceration, and you wouldn't give it if a child's got kidney problems, which might make that worse. But generally speaking, both those medications given together provide quite good pain relief. For children with moderate or severe pain, then usually that's where we're using opioids. And for children under palliative care, then oral morphine is the best. It's again, as I said, to be given by the clock. You shouldn't give it whenever the pain occurs. You should try, for children under palliative care, you should give it regularly, and that could be every 4 or 6 hours, and titrating the dose from quite a small dose to a much larger dose if the child becomes more used to it over time. Now, if oral morphine is not available, it can, as I said, it can be given subcutaneously or intravenously, and I find the subcutaneous infusion to be quite effective, and it means the child doesn't have to have an IV drip. They have a butterfly needle, a fine butterfly needle, just in the subcutaneous tissue, and that can be very effective. IM pethidine is not a very good idea because it's painful. It's a painful IM injection. If morphine doesn't relieve the pain, then there are other opioids, but we won't discuss them because they're not generally available. Fentanyl and hydromorphone, they're both effective, but I think morphine is probably the best, most widely available agent we've got. It's good to try to think about what else you can do. So adjuvant treatment for pain beyond paracetamol, ibuprofen, morphine, and sometimes local anesthetics can be quite useful. So, for example, if a child's having a painful procedure in the skin or the soft tissue, then lignocaine can be infiltrated in the skin or the subcutaneous tissue just with a very, very fine needle, like a 24 gauge needle, but still you're doing something that's a bit painful to a child. So it's best not to do that apart from for a painful procedure. You can get lignocaine gel that you can apply to the mouth ulcers, particularly for children who've got mouth ulcers. You can apply it on a gauze pad, or sometimes older children they can be taught to do it themselves. And it acts quite quickly. Most of these local anesthetics are fairly short acting though, and so they're not a solution to ongoing pain, really. They're for short-term solutions. There is a compound called tetracycline, tetracaine, adrenaline, and cocaine, TAC, and that's good to apply on wounds. And on skin wounds in the skin, TAC, tetracaine, which is like lignocaine, adrenaline, and cocaine. It comes as a product called TAC, and the only thing is don't put it on mucous membranes. It can be absorbed from mucous membranes, that's all. Sometimes children have different causes of pain, and sometimes adjuvant treatment like diazepam or baclofen can very much help if they've got muscle spasm. Sometimes they may have a condition, a musculoskeletal condition causing severe painful muscle spasm, and some diazepam or baclofen can help that. For bone pain, then again, ibuprofen's helpful, aspirin can be helpful, even steroids can be useful. Prednisolone can be useful for bone pain. Although that has to be balanced very much against the damaging effects of steroids on bones, which is osteopenia. So probably use non-steroidal anti-inflammatory drugs first, ibuprofen, indomethacin, aspirin, etc. For neuropathic pain like nerve root pain or any for children with cancer or polyneuropathy that's affecting nerves, then certainly there are a number of agents, particularly carbamazepine. So carbamazepine, the anticonvulsant, is quite good, and another agent called gabapentin is also quite good at for neuropathic pain. And for some children that are got complex chronic pain that might be involving nerves, or it might be involving their bones, then or other pain, when simple analgesia and morphine and other adjuvant therapy hasn't been that effective, then I often put them on carbamazepine or put them on a tricyclic antidepressant, because sometimes that can lift their mood, and it also has an analgesic effect. Tricyclic antidepressants like amitriptyline or carbamazepine. Don't try them all, just try one in a controlled way over a week and see if that is effective. Many children who've got palliative care needs have the gastrointestinal symptoms like anorexia or nausea or vomiting, and certainly in a terminal illness, a loss of appetite is very common. So I always encourage parents to provide food that the child enjoys, whatever they really enjoy, and often it's good to try giving small feeds more frequently rather than 2 or 3 large meals a day, particularly in the morning. Often the child's appetite is better in the morning. So if they're nauseated, then giving cool foods rather than hot foods is helpful. Avoid spicy or very salty foods, because that can make children nauseated, and give some oral metoclopramide. That can be helpful as well. If the child has nausea or vomiting, that can be helpful. So there are things you can do to help a child's gastrointestinal symptoms and enable them to, I guess, food is of comfort, isn't it? It's a comforting thing to still be able to eat, and especially food that you enjoy. And so doing as much as you can to enable them to enjoy that food is helpful. Pressure sores, we all know how to, prevent pressure sores, but obviously you teach carers to turn the child at least every 2 hours and keep their heels elevated off the bed. When you every day, for a patient who's bedridden and needing palliative care, then you should keep the skin moisturized. So use a moisturizer over all the skin, and once a day at least inspect the child's all the body, especially taking note of the pressure areas, the elbows, the knees, the heels, the sacrum, sometimes over the shoulder blades if a child's lying down. You need to know the pressure areas and teach families about the pressure areas, and they can, as they're applying the moisturizer that they put on the child's skin, then they can pay attention to those pressure areas and alert you if there's any redness. A pressure sore starts with redness. It doesn't start with an ulcer. It's redness for many days, usually, before an ulcer actually occurs. But if an ulcer does occur, then keep them clean and dry. You need to change the dressings if they're weeping or exudative. Sometimes local anesthetic can help, like the topical local anesthetic, not injections, but over the skin local anesthetic can help. But that if the pressure area is very painful, but perhaps more importantly, just keep pressure off a pressure sore. For most children, if they're getting some nutrition, if their immune function's okay, and if you keep pressure off a pressure sore, then it will heal. And it's a very important thing for us to be able to avoid, because pressure sores really cause a lot of deaths in children if they're allowed to happen. For infected wounds, then try oral antibiotics for children who are under palliative care. Usually oral antibiotics is good. And if a child's got a tumor that's fungating, sometimes children have external tumors that are fungating, then I always apply or give metronidazole, because sometimes that can be quite painful if they get an anaerobic infection there. So oral antibiotics, including metronidazole, can be quite useful for that, for the relief of pain from an infected tumor. Mouth care is really important for children, all children actually in hospital, but children who have palliative care requirements. And you should teach the carers to wash out the mouth after every meal. If a child can do it themselves, then teach them to do it. But if they can't, then teach the carers how to do it. And they should, if possible, like at least twice a day, you clean their teeth and their tongue and their gums using fluoride-containing toothpaste. This is very important. I mean, these things we often think of just nursing care, but as doctors, we need to know about this palliative, these aspects of palliative care too. If a child's got mouth ulcers or sores, which many children do if they've had chemotherapy or if they've been undernourished, then you can clean out their mouth sores with just clean water or a salt solution or chlorhexidine mouthwash, and apply. Often we apply gentian violet to any major ulcers, which can be applied in the mucous membranes as well. And then giving paracetamol if the child's got the mouth ulcers are painful can be helpful. If a child's got thrush, then giving miconazole or nystatin can be helpful. If it's very bad, if they've got immunodeficiency, HIV or some other form of immunodeficiency, and they've got oral or esophageal candidiasis, then giving them fluconazole or ketoconazole can really help their oral pain. So if a child's got pus in the mouth, then obviously you're going to treat the secondary bacterial infection, and you can use ointment, tetracycline or chloramphenicol ointment. And if the child's got foul smelling breath with evidence of mouth infection, then putting them on antibiotics or benzoyl penicillin, and usually oral metronidazole if they've got foul smelling breath as well. And many children find relief if they're sucking ice cubes or sipping cold drinks, or they're the most important. But I think that they're things that parents can do. If a child's supplied with some ice cubes, they can suck on them. That can be very very soothing for them. There's some other lip balms or paraffin or petroleum jelly that you can put on mouth sores or on the lips to stop them cracking. That can be useful as well. But I think sucking ice cubes and drinking cold drinks is quite often kids want to do that. So constipation is a very common problem for children under palliative care. Because of opioid requirements, because of immobility, if we're not moving around, then we get very constipated, or because of poor oral intake. And so you can try to prevent that by a high fiber diet, making sure the child's having sufficient water. If they can't drink enough, then by nasogastric tube. Don't let them get dehydrated, but enable them to have plenty of water. You can add a stool softener like Caloxyl or Senna. Caloxyl with Senna is Caloxyl is a stool softener. Senna is a bowel stimulant. There are many different brands of docusate sodium, which is marketed as often as Caloxyl, but there are others. And then in addition to that, I find for children that are very constipated, then some sort of osmotic laxative can help. And lactulose or macrogol is another osmotic laxative. It's marketed as Movicol, which is there's other brands as well, but Movicol and Caloxyl, I would often have patients on both of those things, and very occasionally you need to give an enema. But if you think about it early on, then the child won't get so constipated that they will require an enema. So high fiber diet, if you can, or some fiber in the diet, some apples or fruits or whatever, sufficient water, Caloxyl with Senna if you can, and Movicol is what's needed. In the terminal stages of an illness, many children have quite severe dyspnea, and that's distressing, and we should try to relieve that. And so most of my patients who have undergoing end of life care, they're on morphine. That really helps to relieve the discomfort of dyspnea in the terminal stages, and oxygen. What oxygen often does is to help them, well, relieves their hypoxemia and means that they can be awake. If they've got some morphine on board, then they can be awake and they can be usually pain-free, and they can have their dyspnea relieved, and often they're able to talk to their family and be interactive even in the final days of their life. I've talked about this at the start, but it's really important to have a psychosocial and if the family are so inclined, a religious support for the dying child and their family. And I find it really helps to help parents go through that emotional reaction to their dying child. They often have very different reactions, but many families have a sense of hopelessness, sometimes anger, sometimes guilt, often powerlessness, because they can't, for many children, they may have gone through a long period of treatment and they had hope that the child was going to survive, but there comes a point, perhaps, when it's clear to everybody that they're not, and the focus has to be on making the child comfortable. But families often have a sense of powerlessness at that time, and it's really important to address that and help them through that period. I find families, as I said, that have cultural beliefs about death and dying often give them very great emotional strength and resilience. And it's good to find out about whatever community home care programs there are, because getting one community members involved in a child who's in hospital or enabling a child to go home is home for palliative care, excuse me, can be very useful. And lastly, I think it's useful, sorry, I think it's quite useful to follow up. Oh, sorry. I try to follow up on children who've died, and I try to write a letter to all families, a condolence letter that often is a medical explanation for why their child died, if families want that. And it may be an offer of a follow-up meeting where the family can come back and have their questions answered, but also try to link them to bereavement counselling or parent support groups or sibling support. Don't forget the siblings. If a child dies, then their siblings will often be very traumatized by the death of their loved brother or sister, and they need support too. These are things that you can address a bit better, sometimes after the child's died, as well as when the child's dying in hospital. I always try to get allow siblings to come into the hospital to meet with their dying brother or sister. I think that's very important, that they are able to be there and to say the goodbyes and hold them, and it's very important. But the siblings often as traumatized as the parents, and they often hang on to that for a very long period of time. Um, so I try to write, if I can, a letter of condolence to all the families, and that not all families want to come back and have a meeting, but many do, and that can be quite helpful. So that's all I really wanted to say today. We've covered lots of different aspects of palliative care, and as I said, we it's not something that we have discussed too much in the past, but I think it's fundamental that as pediatricians we really know this sort of information. So I hope that's been useful, and I'm going to stop the recording now, and happy to answer any questions that you might have.